Hello, everyone, and welcome. This is Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I am Marie Terrell, Director of Product Management with Persyst, here to introduce our speaker and topic for today. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their experience and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. And you can visit www.persyst.com/grand rounds to keep up to date. Next slide, please. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. Next slide. Wonderful. Okay, so before I introduce our speaker, there will be time for questions after the talk. There is a Q&A button at the bottom of your screen where you can type your questions. And this webinar is also being recorded and will be made available afterwards. So today we welcome Dr. Yoo as our speaker for today. Dr. Yoo is an associate professor of neurology at the Icahn School of Medicine at Mount Sinai. She received her neurology residency training at the Mount Sinai Hospital, followed by a 2-year fellowship training in epilepsy and EEG at the Comprehensive Epilepsy Center at Yale University. After her fellowship, she returned to Mount Sinai to join the faculty. She is director of the Epilepsy Fellowship and Epilepsy Clinical Trials Research. Dr. Yoo is a clinician, educator, and clinical researcher. She monitors and interprets EEGs for patients in the epilepsy monitoring units, intensive care units, and in ambulatory settings within the Mount Sinai Health System. She sees patients ages 12 and up and is passionate in the care of patients with epilepsy and seizure disorders, including those with drug-resistant epilepsy. She performs a thorough surgical evaluation for the patients with drug-resistant epilepsy with the team and is devoted to improving their quality of life. Dr. Yoo's clinical and research interests include medical management and the pre-surgical evaluation of patients with epilepsy and their long-term outcome, cognitive and behavioral aspects of epilepsy, and EEG monitoring. She is board certified in neurology, epilepsy monitoring, and critical care EEG monitoring. And so today, Dr. Yoo is going to be speaking on birds watching in the hospital. BIRDS standing for brief, potentially ictal rhythmic discharges. And the learning objectives are to understand the definition of electrographic seizures, electroclinical seizures, and BIRDS, understand the clinical significance of BIRDS in critically ill patients, contrasted with understanding the clinical significance of BIRDS in non-critically ill patients. And with that, Dr. Yoo, please take it away.
Thank you, Marie, and for having me here. And it's a great honor to be here. And I'm really excited to talk about my favorite topic, birds. And I will take it away. So this is Mount Sinai Hospital right by the Central Park in New York, where I was trained for residency. And right here on the top floor, when I was a PGY4 resident, I was walking to see a neurology consult patient, and I spotted the bird actually over here. And I didn't know that I would be talking about birds watching in the hospital back then. Here are my disclosures. And here are the objectives for today's webinar. So let's take away with the first objective to understand the definition of electrographic seizures, electroclinical seizures, and BIRDS. I will start with the case. This is Mr. R. He is a 59-year-old man with a history of epilepsy on levetiracetam. He had this history of right occipital stroke, diagnosed at age 57. He was presenting with sudden left-sided vision loss while he was on the way to the emergency room because he was having this headache and confusion for the past few days. On further questioning, he said he's been having episodes of seeing flashing or blurry things in his left visual field, and his wife noted that he was spacing out when this was happening. On neuroexam, he had a dense left homonymous heminopsia. The CAT scan in the emergency room showed this some hypodensity in the right occipital lobe. And for this, he had an urgent MRI, which showed this finding, the hyperintensity in the right occipital lobe, which was read as possible acute infarction. However, given this gyral pattern, we thought this could be reflecting ictal activity. He was connected to the continuous EEG monitoring, and this was the first hour of EEG spectrogram showing multiple seizures happening about every 2 minutes. And it's showing seizures coming from the right side with increased rhythmicity and power, and right side driving the asymmetry and a higher amplitude with each seizures. So this was correlating with this raw EEG finding, which the seizures are starting with fast activity over the right occipital region, spreading to the right hemisphere, and slowing down with this periodic activity in the right side. So as this was recognized and he was getting treated with seizure medication, you can notice that the power and rhythmicity is getting down with shorter seizures. And this raw EEG at this time was showing much shorter seizures than how it was before. By the next day, he was much better. He was improving with left visual field, and his EEG was showing this finding now. Starting with similar fast activity over the right posterior quadrant and evolving, but this was not over 10 seconds, and this would be what we are going to focus on during today's talk, which is called BIRDS. So I followed him up as an outpatient. I repeated his MRI 3 months later, and his MRI finding shows a complete resolution of what was seen before, and now this was read as probably reflecting the periictal activity at that time. And his left visual field had completely resolved, and he's doing well still. So continuous EEG, as you all know, this is an essential diagnostic tool to assess subclinical seizure activity or non-convulsive status epilepticus in patients who have persistent or fluctuating auditory status, or who have focal neurological deficits that are not otherwise explained. The American Clinical Neurophysiology Society recommends continuous EEG monitoring in patients who have persistent auditory status following a generalized convulsive status, or who has supratentorial brain injury with alteration of ventral status, or having fluctuating or unexplained alteration of ventral status without acute brain injury. According to the ACNS standardized critical care EEG terminology, the electrographic seizures are defined when epileptic form discharges averaging over 2.5 hertz for more than 10 seconds. It can be over 25 discharges in 10 seconds as well, or if there's any pattern with definite evolution and lasting over 10 seconds. So for example, here in this picture, you're seeing focal epileptic form discharges over the right side happening at over 2.5 hertz, lasting over 10 seconds. So this would qualify as a electrographic seizure. This picture is showing generalized epileptic form discharges. Sometimes it's actually happening at more than 2.5 hertz over 10 seconds. So this would also qualify as an electrographic seizure. And in this picture, you are seeing epileptic form discharges that are evolving. So when there is this spatial temporal evolution of epileptic form discharges lasting over 10 seconds, this would also qualify as an electrographic seizure. Then what is electroclinical seizure? there are two case scenarios. One is definite clinical correlate, time lock to the pattern, and this can be of any duration or any frequency. So for example, if you are having left-sided LPDs at 1 hertz for 5 seconds, and if you have the time-locked twitching on the right side with that, that would qualify as an electroclinical seizure. Or there's another scenario where you have EEG and clinical improvement with a parenteral anti-seizure medication, which is often commonly seen in the IIC. So here is an example of patient who had a cardiac arrest, and you're seeing this generalized polyspike waves happening about at 1 hertz. And sometimes you see this overlying EMG artifacts, and this was correlating with the patient's facial twitching. So this, in this case, this will qualify as a electroclinical seizure. This is an example of the IIC, the ictal-interictal continuum, where we see this epileptic form discharges but are not meeting the seizure criteria. So it is less than 2.5 hertz, and these are generalized, and you sometimes see this triphasic morphology and sometimes biphasic morphology. And it's happening at about 1.5 to 2 hertz, lasting over 10 seconds. So this would be called as the ictal-interictal continuum. In this particular patient who had an ESRD on hemodialysis, he was admitted with sepsis, and he was actually given cefepime. And this was, he was connected to continuous EEG monitoring because of altered mental status. And he was given IV anti-seizure medication. However, he went on to have a seizure, actually. And after he received hemodialysis, he actually improved a lot with awake background like this, and clinically improved. So but then in other patients, if you see this kind of IIC pattern, and if you give an anti-seizure medication and you see this EEG and clinical improvement, the previous pattern would be considered as electroclinical seizure. So here is this question: why do we care about this frequency, and why does it have to be 2.5 hertz? So I like to show this study. This is an EEG looking at periodic discharges and their brain tissue hypoxia in acute brain injury patients. This included 90 comatose patients with high-grade subarachnoid hemorrhage on continuous EEG and multimodality monitoring. And what they observed was that there was increased global cerebral perfusion pressure with increased periodic discharges frequency. However, when it went up to 2.5 hertz, it started to actually decrease. And the median partial pressure of oxygen also started to decrease with higher frequency of periodic discharges. So the conclusion of this study was that, similar to seizures, cerebral blood flow increases in patients with periodic discharges to compensate for the increased metabolic demand. But there is at some point this metabolic supply and demand mismatch, and that's causing that is seen in periodic discharges that are over 2 or 2.5 hertz. So when there is this metabolic supply and demand mismatch, it can result in perineuronal injury. Sometimes it can cause swelling and mass effect even, and it can lead into worse functional outcome. And now let's go into the next question. Why is there the 10-second rule? Clearly, it's an arbitrary number, and the answer is mainly historically. So historically, the definition of seizures included a minimum duration of 10 seconds, reflecting the typical duration of focal seizures in patients who had epilepsy. And these rhythmic ictal appearing patterns lasting less than 10 seconds were described in neonates under many different acronyms, including like brief rhythmic discharges or brief EEG rhythmic discharges, brief ictal rhythmic discharges. And when it was described in neonates, these patterns were of any frequency, including less than 4 hertz, because they were commonly seen in this neonatal group. But ictal discharges in children and adults often have higher frequency than those in neonates. So we wanted to study this in adult population. So we will go into the next objective to understand the clinical significance of births in critically ill patients. So I will start with the case again. This is Miss A, who is a 57-year-old woman who had endocarditis, who had a convulsive seizure 2 hours post-op. And the EEG was showing this abundant bilateral independent occipital epileptiform discharges. And this patient went on to have a seizure coming from the left occipital region like this. And during her EEG monitoring, this was also seen in the left occipital region, starting with faster frequency and evolving to a slower frequency, lasting about 4 seconds or so. And in this EEG, also this kind of activity was seen, which didn't really have a clear evolution because these were short, lasting about 0.5 to 1 second or so. And when I was showing this picture to my residents, one of the residents raised his hand and said, Dr. Yoo, this looks like angry, so let's call them Angry Birds. So I put a picture of Angry Bird in here. So births in critically ill adults were described in 2014. These were defined as very brief lateralized runs of rhythmic activity over 4 hertz with or without evolution. The prevalence was not that high. It was about 2% in this critically ill population. And they were most frequently in theta frequency and lasted about 1 to 3 seconds. And compared to the age and etiology matched controls, people who had births had higher seizure risk and worse functional outcome and higher acute brain injury risk. And seizures often started with the same, very similar morphology, similar to the birds, and within the same region. And interestingly, birds ceased when seizures were controlled. However, the lateralized periodic discharges, or LERDA, often persisted. This is another case of 88-year-old man who had an acute brain injury. He was having left facial twitching and he was connected to EEG. You can see the subarachnoid blood in the right side. And this was what his EEG was showing. There were frequent seizures coming from the right side. And as the seizures were controlled, these seizures are getting better on the quantitative EEG. And the raw EEG was also showing the seizure activity becoming shorter and shorter. And this would be what would be called as evolving burst, and this would be a non-evolving bird. So the birds can be considered kind of in the IIC picture in these critically ill patients who had acute many seizures and electrographic status epilepticus. And when they are getting treated with seizure medications, you can often see this pattern as well. So in this study, looking at the seizure risk prediction, in this foundational study, they looked at all the factors that could lead into seizures. And as you can see here, birds were very much associated with seizure risk with odds ratio of almost 19. And then for this, in this validation study, and foundation study as well, the birds were given 2 points for seizure risk, and all the other points are 1 point, including for frequency of 2 hertz, independent sporadic epileptiform discharges, LPDs, BIPDs, or LERDA, or having plus features, and for clinical history of prior seizure. As you can see in here, if you have 2 or more points, you need at least 24 hours of continuous EEG monitoring. So if you spotted a bird, that will automatically give you 2 points, and that means that you need at least 24 hours of continuous EEG monitoring not to miss a seizure. So here's our first question. So what are these? And I hope this poll works well, and I have these answer choices. Okay, great. So people have voted periodic birds for 53%. Okay, so This answer is actually artifact. This is not periodic burst. This is actually respiratory artifact. In people, this is commonly seen in patients who are in the ICU, who are trached or on ventilation. So this is basically water in the tube, like moving a little bit with each respiration. So this is a respiratory artifact, not birds. There are a lot of artifacts happening in the ICU. So I think it's important and interesting to look at these and identify these artifacts. All right. So let's go to the next objective, which is to understand the significance of births in non-critically ill patients. And these include patients who are in the epilepsy monitoring unit or who had an ambulatory EEG monitoring. So I will start with the case again. This is a 25-year-old woman with epilepsy who was admitted to EMU electively for pre-surgical evaluation. An MRI showed a polymicrogyria in the right parietal region, and this EEG showed a sharp wave on the right side. And this was seen on her EEG as well. It looks like an evolving bird here. And this is another example of another bird, which is non-evolving in this case. And this doesn't look as angry as the other one. So I put a picture of hummingbird in here. So this was described as like births in non-critically ill adults. This was a single center study, and the prevalence of the births in these patient population was lower than critically ill patients. It was only seen about 1 to 1.2%. And at this time, definition of births was modified to include the generalized discharges as well, because we saw them. And all patients with births had epilepsy. And interestingly, they were more likely to be drug resistant, and the scalp EEG seizure onsets co-localized to births in all the cases. And in this population, it was important to distinguish these births from normal or benign variants, because you see this kind of rhythmic patterns as a benign or normal variants in people who are not critically ill. So this is an example of diffuse theta slowing, where you see in the transition of awake to sleep. So there's awake background and there's diffuse theta slowing, and then going into sleep background. So this would be just a benign drowsy pattern. And this is a mu rhythm that you see over the right and left central region during awake background in the alpha frequency. So that would be a mu rhythm. And this is a train of wicked spikes or wicked waves that you see in the temporal chains in the drowsy state. And this would be benign variants as well. And this is an example of 14 and 6 positive spikes that you see like over on the average montage. It's going downwards, which means it's positive. And it's often seen in young adults who have in drowsiness in more like posterior temporal regions, also a normal and benign variants. So when you look at this morphology, this can be mistakenly seen, noted as birds. So when we were looking at this, we thought this was very important to have a very concise definition. So the definition was developed as focal or generalized rhythmic activity over 4 Hz lasting 0.5 to 10 seconds. Here the 0.5 is because if it's lasting less than 0.5 seconds, it would be a polyspike epileptic form discharges rather than birds. And it shouldn't be consistent with the known normal pattern or benign variants, and it should have at least one of the following features. So if it evolves, then it would be a definite burst. If it has a similar morphology and location to those of interictal epileptic form discharges or seizures in the same patient, that would be also definite bursts. But if it's not any of these, then just sharply contoured, then it would be called possible birds. And in our reports, we usually just only include definite birds as with clinical significance. So this is a 25-year-old man with epilepsy. And here's another question coming up. What is this?
Okay, the poll is launched.
Great. Yeah, so people have chose mu rhythm the most, and there are some answers for right central breech rhythm or birds. So at this point, I think all answer choices are valid because you haven't seen more information until the next slide. So he went on to have sleep, and this is what was seen in his sleep background. There are these right central spikes coming, and he also had this evolving pattern in the right central area, and now this was also seen in the same region in sleep background. So here's our next question. What is this? And we have same answer choices. Okay, great. Yeah, I think this was easier. We now know this is birds because now we saw the same regions interictal epileptiform discharges and also evolving pattern, as well as those same discharges are now rhythmic patterns is seen now in sleep rather than in awake background. So which should not be mu. And also it's not breach because it's not consistently seen and for all the other reasons that we just talked about. Okay, great. So this was included in the official ACN's terminology in 2021 with slight modifications. The modification is that it shouldn't be the part of burst suppression or burst attenuation because, for example, there were seizures in the one patient who was not responding to anti-seizure medications and who was put on anesthesia medications for burst suppression achievement. Then you can see these epileptiform bursts. We would call them as epileptiform bursts rather than birds. And rather other criteria remained the same. So this is an example of evolving birds. And this is interictal, not evolving, but there is an interictal epileptiform discharges in the same region. So this would be a definite birds. And if you had a seizure in this patient, like the same onset, then this would also qualify as definite birds. But if you do not have any of these, then it would be just possible birds. So this is a case of 72-year-old woman who had acute subarachnoid and seizures, and EEG was showing right temporal seizures like this. And this is the last set of question. What is this? Great. So this is a definite non-evolving birds. We already saw a seizure coming from the same region, so this would be a definite birds and it's not evolving. We have one more question. What about this one? Great. Definite evolving birds. Over 80% people got it right. Great. This was fun. I wanted to make it more interactive. And I want to spend the next 10 to 15 minutes talking about paroxysmal fast activity, which is perhaps more interesting than previous talk. The EEG term, the generalized paroxysmal fast activity, has been historically described in Lennox-Gastaut syndrome and other epileptic encephalopathies. And according to the diagnostic criteria for LGS from the ILAE in 2022, they should have multiple types of drug-resistant seizures. An onset of seizure should be prior to 18 years of age. And the seizure should include tonic seizure, and they should have cognitive or often behavioral impairment, which may not be present at seizure onset. And on EEG, They should have diffuse slow spiking wave as well as generalized paroxysm fast activity. And according to that paper, the GPFA was defined as burst of diffuse or bilateral fast, meaning 10 hertz or more activity, often seen in sleep. So this is an example of an LGS patient who has slow spike in wave discharges and multifocal spike and polyspikes and generalized PFA and electrodecrement with tonic seizures. And I will bring this picture over here. So would you call this BERS, PFA? There is an overlapping definition of BERS and PFA. According to the terms, the EEG glossary of terms most commonly used by clinical EEGers, the GPFA is defined as bilateral synchronous bursts of spikes of 2 to 10-second duration with frequency between 10 to 25 hertz and maximal in the frontal regions that only occurs during sleep. Personal fast activity is defined as fast frequencies in the beta range or above occurring in trains with no duration specified. So according to this definition, all GPFA would also qualify as bursts, and many paroxysmal fast will also qualify as bursts. But slower frequency rhythmic activity like this picture would be bursts but not PFA. So here, I wondered if there were any difference between BERS and PFA and started to look at all some papers about this paroxysm fast activity. And the term, so in this paper, the GPFA was reported in generalized epilepsy without cognitive impairment. Generalized polyspike trains was suggested as an EEG biomarker for drug-resistant idiopathic generalized epilepsy patients. The presence of GPFA in absence epilepsy was associated with persistence of absence seizures and also has been suggested to be a marker of lifelong epilepsy. Asymmetrical GPFA was described in drug-resistant focal epilepsy, and focal PFA was also associated with seizure onset zone and seizure severity in children with epilepsy. And regional PFA was seen in patients with drug-resistant epilepsy with underlying gliosis and focal cortical dysplasia. So there has been this work about PFA in these papers. So what I wanted to do is to look at all patients who had BERS and PFA and basically see if the frequency cutoff made any clinical significance. So this study included 94 patients, including both critically ill and non-critically ill patients with BERS or PFA. 74% total had epilepsy, and over half of them had drug-resistant epilepsy. And all patients with GPFA had a history of epilepsy, and 67% of them were drug-resistant. And interestingly, only 14% had epileptic encephalopathy, and otherwise all had generalized epilepsy without cognitive impairment. And a lot of patients had seizures during the same recording, more so in the critically ill population, and scalp seizure onset zone co-localized with the BERS or PFA in all cases. And the BERS that also qualified as PFA had similar seizure risk to that of a slower BERS. So it didn't matter where exact cutoff was used to define the PFA. And interestingly, 100% who had evolving BERS or PFA had seizures in the same recording, and 50% with non-evolving BERS or PFA had seizures. This is another interesting study looking at generalized polyspike train. And this is a single center case control study. They looked at 103 patients, and 70% of them were drug responsive and 30% were drug resistant. And they defined this generalized polyspike train as these discharges lasting less than 1 second. And what they found was that having this GPT was more prevalent in drug-resistant epilepsy patients than who didn't have them. And it took about median of 6.5 hours for EEG to first capture the occurrence of the generalized polyspike train in this paper. This is another very interesting study looking at paroxysmal fast activity as a biomarker for treatment response in patients who had LGS who received deep brain stimulation. So they included 17 adults with LGS in the Estelle study, and they looked at the GPFA and electrographic seizures and electroclinical seizures, and they compared them to their seizure diary. And in this paper, they uh, defined the electrographic seizure lasting over 5 seconds, not 10 seconds, because what they observed was that if they were over 5 seconds long, there was subtle clinical like tonic involvement. So they defined as more than 5 seconds in this study. And they did 24-hour EEG at baseline and repeated it every 3 months. And what was observed was that the GPFA's duration and frequency were significantly associated with diary-recorded seizure counts over 3-month intervals, more so than clinical seizures and more clinical EEG seizures and electrographic seizures. So they suggested the PFA as a biomarker for treatment response. We looked at birds in non-critically ill patients with RNS ECOG. This included 11 patients who had received RNS and came into EMU for various reasons. And we correlated what we saw in the RNS ECOG with a scalp EEG recording. And what we observed was that most of the RNS detections were of very brief duration, and most of them received just one stimulation therapy. And 67% of long episodes were not identified as electrographic seizures, and the birds were the most common EEG findings that were associated with long episodes that looked ictal and did not have scalp EEG seizure correlate. And long episodes that were associated with seizures on scalp EEG had longer median duration compared to those without, and had broader spread pattern, and they were higher amplitude on ECOG. So, for example, these are very brief discharges that are given like one stimulation artifact over here from the RNS, and this is an example of getting 5 stimulation therapy that was not read as an electrographic seizure, but you can see like a bird pattern on the scalp EEG. So in summary, birds, including PFA, is a scalp EEG biomarker for seizure activity and seizure onset zone for both critically ill and non-critically ill patients. And birds correlate well with increased seizure risk for seizures, seen in about 2/3 overall in both critically ill and non-critically ill adults. And birds and PFA can help estimate the patient's seizure burden and to guide treatment. And I want to thank everyone for being here. And I have special thanks to our wonderful Mount Sinai epilepsy colleagues, Nicholas Gaspard, who introduced me into the world of birds when I was a fellow. He was my co-fellow. And Larry Hirsch and Natalie Jete, who are my beloved mentors, and Mount Sinai epilepsy fellows. Thank you so much.
Wonderful. Thank you so much. What a great talk. We have a couple questions already, and to the rest of the audience, now's the time. So type your questions into the Q&A. The first question is, if you have epileptiform bursts in a post-anoxic curve alternating with sharp GPDs on a flat background, but not qualifying for burst suppression, is it then a bird or just a burst?
Those are bursts. Yeah. And if you see epileptiform discharges within the burst, we would call them epileptiform bursts.
Great. Clear-cut answer. Wonderful. Can you explain any reasons to distinguish birds from ERDS, IRDS, in clinical practice? And I'm not sure if I missed that acronym, but maybe you could describe what IRDS is also.
I am not sure.
Or maybe the acronym
IR.
isn't quite right. David Anscheld, if you would like to clarify your question, maybe Not sure that the acronym IRDS is well understood. Okay, he's clarifying it as ictal rhythmic discharges. So what are the
Oh,
reasons to distinguish birds from ictal rhythmic discharges?
um, you mean like not over 10 seconds, like brief, what the clinical significance of birds, like which are very brief, for example. Now, I think your question is about why do we differentiate them? Why do we actually have them called as birds? So I think when we didn't give this name, when you see these discharges on EEG, for even like 1 second long duration of these discharges, like which is very, very brief, and we often don't know what the clinical significance was. And by studying them, we were able to see, even if this was very, very brief, like 1 second long, this was correlating with seizure risk and also drug resistancy of the patients. And you can also see them in a lot of drug-resistant people who need surgery. And that can also sometimes give you a clue where the seizures are coming from. And of course, you will need other seizures captured. But I think it can give you some other significance by just looking at them and identifying them, as we talked about. So I think there is that clinical significance.
Right, because they don't fall under the definition of a seizure. So unless you define them and characterize them, then the clinical meaning would be lost.
Yeah.
Um, okay, next question. Great talk. Thank you. You presented several lines of evidence that suggest that birds are just short seizures. Do you think the arbitrary 10-second rule needs to be revisited? So similar question, it seems.
Right, right. I think that's a great, again, like this is a very hot, was a hot topic of debate. Actually, we did a poll, like, or survey in the CCMRC from the ACNS group, and there were a lot of debate about this. And I think we need to accumulate more evidence, and research should be done. And when we have enough research showing if there is one actually having that duration cut off, then it will maybe be revisited.
Yeah, yeah, I guess it's still a hot topic, huh? Because our next question is, surely the very high correlation of these with seizures is due to the fact that the split is semantic. These are short seizure discharges, yes?
So especially so for evolving seizure birds, I do think those are seizures. And as study showed, 100% of those who had evolving birds had seizures in the same recording. So I do believe those are seizures. For non-evolving birds, that usually is very, very short, can be 0.5 second or 1 second. I think we still need to have a little bit more study about them to see what those are like, and how we can use them as like a marker for treatment response, like some other studies showed. And I think that it has a very good potential to use as a biomarker.
I may have missed this in your talk, but is the definition of birds included that there's no clinical semiology involved with the
That's
birds?
correct. That's correct.
That's
If there
correct.
are, yeah,
Okay.
yeah, if there is a clinical correlate, then it would be just birds. I mean,
Yeah.
seizures.
Yeah. I
Mhm.
mean, so from a very high level, basically your talk is a discussion of, the continuum of discharges that we see in the EEG that are epileptic. Um, and, some have clinical correlates, others don't. And because they are very seizure-like in some ways, but not in other ways, right? Some don't evolve, some don't have clinical correlates. The aim is to try to characterize each of these, define them based on the parameters under which they manifest, and then try to understand how related they are to one another within this continuum of epileptic activity. If we define it as a seizure, that's not quite right because some don't evolve, some don't have clinical manifestation. But if we don't define them at all, then we're at risk of mismanaging patients. So I think
You
semantics.
spoke better than I could do.
Thank you. Yeah. So semantics is tough, right? I mean, we deal with it so much in this field. Everyone can argue over what the definitions are, but I think in the end, the point is that we capture them and try to describe them because the aim is to try to care for our patients. So we can argue about the language and maybe and that's useful clearly because we all want to mean the same thing when we use language, right? We want to be sure that we're referring to the same thing so that we can have a conversation. And then of course semantics can also be a burden. But um, I've always been confused about birds. So personally, this was a very useful lecture for me. I learned a lot, so I really appreciate
Great.
your
Thank
talk.
you.
Um, and then we still have some questions coming in. So the next question I wanted to know with birds, how does their presence inform your treatment strategy in terms of how aggressively to treat them to prevent progression to overt seizures? And is this practice different for clinically ill versus non-critically ill patients?
Great question. So in critically ill patients who have I think we have seen more cases of starting with seizures, and when they are treated with CBERS, like the case I showed you, some those seizures will get shorter and shorter and becoming evolving bursts, and it will eventually disappear when the seizures cease. We see those more so than patients who actually get spurs and going into seizures in the critically ill patients. But if you do see them in the critically ill patients, then it's very highly likely that these patients will develop seizures, like the 2 helps 2B score shows. So in those patients, 24 hours at least will be required to rule out seizures. In non-critically ill patients, like if I do an ambulatory EEG for a patient that I see as an outpatient, and when I see birds in their EEG, then I am alarmed that they are probably having more seizures than they are aware of, or I am aware of, and I want to be a little bit more aggressive in their seizure management, try to figure out more from the witnesses, or trying to get more information about their seizures. And sometimes I just increase their seizure medications and repeat their EEG too. There's limitation of how much EEG you can do in these patients who do not have RNS. So yeah, that's what I do.
I think you also said that in all cases, for the non-critically ill patients that had epilepsy and you were monitoring them in the EMU, that in all cases the birds localized to the seizure onset zone.
Yeah,
So then it would also be a very useful piece of information if you're trying to determine surgical candidacy. Or
right. It
yeah,
is. And we have seen patients who had bilateral independent epileptic form discharges in both hemispheres, and saw bars really on one side, and seizures confirmed to be from that side.
yeah, yeah. Interesting. Okay, can you explain the difference between birds and PFA?
Uh-huh. Yeah. So birds are defined as more than 4 hertz. And the PFA, the literature has been variable. But if you look at their literature, I try to like look at one by one and go into the paper itself and like see how they define the PFA. It's a little bit variable, but most commonly they were defined as more than 10 hertz. So you're missing this kind of little slower rhythmic pattern, like in mostly theta frequency, that would not be called PFA. And that's why I wanted to look at this frequency and see if that actually mattered at all, and compared their frequency as like, is it the high theta frequency only, alpha and beta, like that, and then saw there were no clinical difference, significance difference between those. They all had similar seizure risk, and they all, we just couldn't
Hmm.
find difference.
So then it's possible that they should be categorized in the same bucket.
Yeah, so we suggest to categorize to as birds, because a lot of birds are not fast.
Got it. Yeah. And some of the reason for semantics is because different groups of clinicians are observing different phenomenon in EEG across different patients, and then they come up with their own terms, and then the field has to figure out, oh, is this the same as what you observed over there as what I'm seeing over here? So is this also maybe an example of that?
Yes, so this is why Dr. Hirsch really pulled together this terminology for critical care EEG, because if we were not talking about in the same language, then it can get really mushy and confusing to do research. And once we actually use that same term, then it helps to know that clinical significance. So I think having that terminology in there for now is really helpful to look at the clinical significance for by more research. And again, once we figure out more, then I think we can maybe come up to a consensus about what is a seizure.
Perfect. Yes, the issue of semantics again. There's a question here, and maybe you'll know what this person is referring to. I don't, but it's in the two helps to be scale. Birds are not discriminated by types in punctuation. Do you think it would be necessary in the future, as evolving birds could punctuate more than a possible bird, for example?
That's a
What is
very,
what is the
yeah.
two helps to be scale?
So the 12-2B scale is basically a seizure risk prediction score. So you're given one score for clinical, which is only for the clinical prior seizure, and otherwise it's all EEG finding scores. And like more than 2 hertz, like there is like one score given for each EEG finding. And for birds, it was given 2 points. But at that point, when the research was done, it was not differentiating between the evolving birds or non-evolving birds. So it was all in the same bucket. So I do think if we actually look at evolving and non-evolving birds separately, it will give probably different results. From our study, again, the evolving birds had 100% seizure risk, and non-evolving birds had 50% seizure risk.
Interesting. Yeah, that makes sense. Um, okay, here's an interesting question. Should birds be included in the calculation of seizure burden?
I think so.
Mhm. Yeah.
Yeah, and I think it's a good marker to look at in these drug-resistant epilepsy patients, especially for LGS patients who have all this PFA is like their hallmark of EEG finding. And as the Estelle patient study showed, it can be possibly used as a biomarker for treatment response because it actually gave more uh, association with the clinical seizure baseline diary, then the EEG seizures or EEG clinical seizures that was seen in the EEG. So it has a very good potential to be used as a biomarker.
Mhm. Okay, here's another question. We do see these very often in patients with tuberous sclerosis during VT, and we often report these as brief subclinical seizures. Please comment whether these are only birds.
So I would just follow the definition for now, and um, yeah, and report public, when we see more publication regarding the birds, I think more research will help.
Right. Yeah. And then the last part got me. Please comment whether these are only birds. I think it wouldn't be diminutive, right? Birds are clinically significant. So if they're birds or not birds, to your point, they should be reported on.
Right. In the EEG report, we do report about birds and what frequency they were consist of and how long they lasted, and
Mhm.
to differentiate between those evolving birds versus non-evolving.
Okay, I think this is a follow-up to another question we were just discussing. Someone asks, are you suggesting that 0.5 seconds and 9-second birds have similar significance?
I don't think they have same significance as we talked about. I do think 0.5 second non-evolving, they will, I mean, even though I actually have seen 2 seconds of birds with evolution, very subtle evolution, but I do think there is a difference between evolving versus non-evolving.
Yeah, yeah, that makes sense. Okay, and then one last question, I think, and then oh man, the questions are coming in. This is great audience participation. Okay, how about this one? Birds and GPT, which one will have good prognosis?
So the GPT was including less than 1 second only, and they actually I'm not sure if they included less than 0.5 second as well. Maybe they did because it was including less than 1 second. Yeah, so in that study, they suggested a GPT was better than GPFA for looking at the response. So again, more research is needed.
Right. Okay. And then there's a question, better precise clinical testing would show dysfunction of the area of brain with the discharge, surely. But I think you showed that, right? There was a slide where there was an area where birds were coming from, and there was some hypoperfusion in that area, right? It was the occipital lobe case where the patient had a visual
First
field.
case. Yeah,
Yeah.
yeah.
So there was extra clinical testing that showed that there was indeed an area of dysfunction. Are there more? And then also you referenced that birds in non-critically ill patients localize to the same area of seizure onset. So it sounds like there is additional testing that shows dysfunction. Are there any other examples that you can discuss?
I think this is my long overdue project that I plan to do because we have accumulated a lot of patients who had SEEG, stereo EEG, in these people who had scalp burns, and this is my long overdue project.
Okay, will you please come back and speak for us again? I think that would be very interesting
No
to hear about
pressure,
those
please.
results. Yeah. Okay. Well, that's great. That seems like an intuitive next step to learn more about them. All right, let's see if we can squeeze one more question in. Can a rhythmic sinusoidal pattern with a frequency over 4 hertz be classified as a bird?
Mm, as possible birds. If you do
Possible
not
bird.
have, if you do not have evolution, if you do not have same region of interictal epileptiform discharges, those are not definite birds.
There you have it. Okay, I'm going to let you go, Dr. Yu. This was really a wonderful talk, and thank you so much to our audience for your participation. It really makes it a wonderful learning experience for everyone. So thank you very much, Dr. Yu.
Thank you, Marie. Thank you, everyone.
All right, bye-bye, everybody.
Bye.